to this very, very special occasion. It's a very interesting thing how we go about this whole area of diagnostics. How do we help a patient arrive at the correct diagnosis, correct treatment? How can we make it affordable? How can we make it available? How can we make it cost effective? And how can we do the best? Whatever is happening in the world should happen in India, should happen in Tamil Nadu, and should happen. So in 1981, Dr. Sushil Shah founded the laboratory Metropolis. And he always said, let us be the doctor's doctor. Let us be every specialist doctor. There are so many clinical specialists, right? You have a gynecologist, you have oncologist, you have orthopedician, you have a gastroenterologist. There are so many clinical specialists. So in Metropolis, we have 250 doctors. And each one of us is a specialist in something or the other. So he said, let us handhold the clinician and the patient in the area that they needed, and let us do subspecialty pathology. So we were the first to start with subspecialty pathology in the private sector. And the same goal is what we are continuing with. The cost is very important. India is a resource-poor country. Funds are not available. Everybody is not insured. So just because somebody cannot do the test or cannot afford the test, he should not lose the right to good patient care. So the whole concept is to make it available, but make it affordable. As the innovation and the R&D arm of Metropolis, this cell, the MHL Innovation Cell, the launch of which we are discussing and the purpose of which we are discussing, the whole pursuit is of scientific discovery to help patient management. Just basically fuel the company's vision and mission of being the most trusted scientific brand and to give inner health information, but with a lot of compassion, a lot of empathy, honesty, and accuracy. So we have multiple specialties, as I spoke about. We have gynec expert, neo expert, pediamet for women and child health. We have oncomet and histo expert for oncology and histo, which is any tissue that comes out of the body. We need to see whether it's cancer or not, and if it's cancer, which type of cancer, grade, stage, everything. Similarly, chronic diseases. Today, all of us are subject to lifestyle disorders, chronic disorders. They have to be managed very well. So we have micro-expert, gastromet, nephromet, cardio, diabetes, osteo, everything. And now, the new member of our team is the genome expert, which is molecular genomics. What happens is a very interesting thing, The tests have been available, right? It's not that the test is not there. But just because something is available doesn't make it possible for a patient to get access to it. So here is something, we started a very interesting thing called the reflex testing approach. So I'll take a minute to explain what is reflex testing. Now, you imagine a scenario, there is sequential testing. Means you do a test, you go to a doctor sees the report, then tells you another test. Maybe after a week or 10 days, you get another appointment, then you go again, and the cycle continues. What happens with that? You lose time. Most important thing, you lose time. So with reflex, what happens is that initially only we have thought that this is what is going to be required for this kind of a patient. And we bundle that test into the strategy. And the moment the case comes as a detected or a high risk or a positive, immediately we pick up the phone, talk to the doctor, tell him, look, this has come positive. So do you want us to add this test now in it? And then when it gets added at no cost or at minimal cost. And immediately 50% of the cost and 50% of the turnaround time are just the patient is the beneficiary of this. So this reflex testing is something for which we won the FICCI award. We were nominated and awarded by the special jury of FICCI for this concept that we brought in. Because there is a huge concept, a benefit of reflex testing. First is the cost. Second is the timely diagnosis and treatment, as I told you. And these are generally very life-threatening and life-saving situations. So it's direct impact on life. And obviously it changes the entire landscape of the country. So if you have a certain budget, if the government of India is sitting with a certain budget and they had to do it in X amount of money, now they can do it in half the X of money. Or maybe sometimes even 25% or 10% of the initial cost that was imagined, just because of the reflex strategy. So when we applied this to pregnant women, just see the magic that happened, right? So today, if everybody gets pregnant, and it's good to see that, the way we are moving forward in this whole cycle, all thanks to the government initiatives and to the local initiatives, everybody is very aware. So though family planning has set in, there are a lot of people who are somehow unable to conceive, and when they finally do, that child is very precious. Now, we want the children to come into the world, but we do not want special children to come into the world, right? So that is a burden on the family and a very emotionally trying time for the family and for the child. So now what is very interesting in this space is that obviously the age of the lady is important, smoking history is important, the radiology findings, sonography findings are important, and then there are some blood markers. But what happens that every time, just with the serum testing, you cannot, be very sure of whether the child is going to be a Down's baby or is going to have a chromosomal abnormality or not. But where was the problem? Where is the struggle? That though the NIPT, that is the non-invasive prenatal testing screening, is available, everybody cannot do it because it's expensive. It's so expensive that half the people cannot do it. So we came out with this revolutionary concept of PregaScreen, and it changed the whole dynamics of the situation. So each and every pregnant woman who got tested at Metropolis in the last 1 year for PregaScreen automatically was offered the NIPT and the karyotyping free of cost, actually free of cost. And what happened with that? Complete magic. So if you see, only very, very few people, I'll take you to the larger indices. So let's say out of 62,000 women who got tested, 1182 were high risk, but actually only 0.2% of these ultimately came out to be true positive. And your very own Chennai data just showed a 1% incidence. Can you imagine the magic of this? Now, these 62,000 women would never have done the NIPT upfront because, it's very expensive test. But when you bundle it and reflex it with a serum marker or blood marker or a clinical marker, you're able to achieve that outcome. So this whole PregaScreen algorithm starts with a very, very cost-effective serum-based test. Then only the high-risk cases are offered the NIPT, and these NIPT positive cases can even do an invasive test like chorionic villus sampling or amniocentesis, which is also again free of cost. And then ultimately you decide, okay, now this child, is, fine, normal, and, can come into this world, while the one who is unfortunately special, needs to go for a medical termination of pregnancy. For this, we were awarded recently by the IHW Council, that is the Indian Health and Wellness Council, and we received the award for patient centricity and advocacy for this PregaScreen concept that we launched. Now moving on to another very important topic, cancer. So we all know today what a burden cancer is in this country, and how many of our esteemed, oncologists and oncosurgeons are working very hard to control not only, the detection, the treatment, the overall survival, the progression-free survival, and there is a lot of work happening around that. But what is very interesting again is that 5 to 10% of these cancers which are hereditary, or even if they are not hereditary, there are some biomarkers which are important for the testing. Now again, these sometimes, among them the most troublesome is the BRCA1 and the 2, which is the most penetrant cancer gene. And we know that 7% of breast cancers and 15% of ovarian cancers are just because of this mutation. And especially when you see women who develop cancer early, or in their whole family they have a lot of cancer, or there is a male breast cancer, or it's on both sides of the body, and various other markers are there by which we know that this patient could be a BRCA positive case. But again, BRCA is an expensive test and not available. How to make it available to everybody who needs it? And today it's not only for detecting whether you could be having it, but also from a treatment point of view, because now there are drugs available, and especially for prostate cancers, which are castration resistant, and other cancers, and even in the treatment of breast and ovarian cancer, you have to know whether the patient is a BRCA positive or not. So again, when we looked at this data of ours of more than 500 individuals in which we had the hereditary breast and ovarian cancer or the ovarian cancer population, and this is what we see. And again, you will see that even look at your own data, let us say Chennai, we are seeing a 16.7% positivity of this mutation. That is a very, high incidence to detect and to pick up. And overall in the country, and as published by some more centers of excellence, I saw a couple of articles before coming over here, and I'm seeing everybody has published around 20 to 25% incidence, which is again a pretty high incidence to have. And if we are sitting on such an incidence, we need to do something about it. So to close with another very important thing, lung cancer. So again, for lung cancer, it's been a very, these are some of the most common cancers, and as you can see, this is the global data, the Indian data, and the Metropolis data. So we've tried to solve the most common problem first, but we have got a big R&D pipeline to take care of all the cancers that we're coming across. So I'll tell you something very interesting about lung cancer. So before this whole molecular genomics came into the picture and molecular markers came into the picture, the survival, and I think Dr. Anita ma'am will share much more on this, that what the overall survival of a lung cancer patient, especially if he was metastatic, looked like, The 5-year survival rate used to be very low. And today that 5-year survival rate has just, jumped from 15 to 50% because 75% of lung cancer patients have a biomarker. But are we able to find these biomarkers? Are we being able to test them? And that is the whole idea. So again, just to share with you some data at Metropolis, these are the 15% of all the lung samples that came to us from 15 to 21. That is about 8,500. 15% of them were malignant. And when we tested these for molecular markers, we can see that all these mutations combined together with the EGFR of 25% and all the other markers, in close to half the patients, you can find the molecular marker by next generation sequencing. So next generation sequencing, or NGS, is a very, very important tool of the diagnostic arena today. But I do not believe, and Metropolis does not believe in having it as a standalone tool because it is very expensive. The whole idea is to, put it in the algorithm, in the testing algorithm, so that each and every patient who needs that test gets benefited by that test. And that is the whole idea of, innovating and, using artificial intelligence, using molecular genomics, using digital pathology, using reflexing algorithms, and somehow making the test affordable and available with the right quality. Thank you. With that, I would like to invite Dr.